my goal here is to talk about coding. Now, a lot of times coding doesn't change very frequently. So I'm going to focus on some specific procedure codes, and then I'm going to talk a little bit about E&M codes, and then I'm going to put some shameless plugs in at the very end that you all need to pay attention to very closely. So every January, new codes are enacted into the Medicare fee schedule, and 2023 January was no exception. So there is a new code, for those of you that don't know, for radio frequency ablation of the nasal valve. That code is 30469. It pays 2.70 work RVUs. When you are getting reimbursed for a procedure, you're reimbursed in a couple different ways. One of them is for the work that you do. The other is for the equipment that you use. And so while someone may look at this and say, oh, that's not really many RVUs for a procedure, while that is true, there is a practice expense component of this that is separate that reflects the cost of both the reusable console as well as the non-reusable hand pieces for radio frequency, unless you work in a clinic in Georgia or North Carolina or something like that. You just clean it up, apparently. So one of the things that I always stress whenever we're talking about new codes is codes don't equal coverage. This is in the Medicare fee schedule. Medicare will pay for this. Cigna, Blue Cross, private payers, they make individual decisions based on individual codes and may consider something like this experimental. That is not unusual for any of you who have tried to do things like balloon dilation of the eustachian tube with private payers. Many carriers say that that's just experimental and you're not going to get reimbursed for that. That is a long process that it takes to move a payer from experimental to actually approved. I think it's a lot less based on evidence. They really just want to make sure that it's going to be cost effective for them. Another new code, neither rhinologic nor otologic in nature, but still present, is for drug-induced sleep endoscopy. 42975 is the code, and it pays 1.58 work RVUs. Now you may say, why is it so small? It's because when we ask people how long it takes them, they tell us it doesn't take very long. And when I say people, I mean members of the American Academy of Otolaryngology head and neck surgery. So I mean probably many of you. So when we ask people and we send out anonymous surveys, always keep that in mind, that what one gets reimbursed for something is all based on how long it takes them. Switching more to some of the otologic new codes, there's new codes for BAHA. So I am about 3 years into this process and have finally finished this. I've learned more about BAHAs in the past 3 years than I ever knew in residency, than I ever knew at any time. We're all familiar with the traditional percutaneous BAHAs. There's transcutaneous BAHAs, and there was a move to get specific coverage for those transcutaneous, because there was a feeling that they were very different from the percutaneous, which then led to creation of codes for the transcutaneous. But then you say, well, but the percutaneous, we got to figure out how that fits in, so we got to change those values. This all depends on the transcutaneous ones all depend on how much bone is removed during the procedure. And so if you look at these new codes for the transcutaneous, and all of the families are kind of divided like this. There's implant codes, there's revision replacement codes, and then removal codes. So this is if you're removing less than 100 square millimeters of bone removed. So everybody get out your rulers if you're doing this procedure. And again, these are new codes as of January 2023. These are implant, revision, replacement, and removal if you have removed greater than 100 square millimeters of bone. And then these are the traditional percutaneous BAHA codes. And I put up the new work RVUs, and I put up the previous work RVUs as well. And for anyone that does these, this was kind of a bad day at the office to see that. So you can see greater than 50% decrease in reimbursement for these. And again, why was that? Well, it was mostly because they may have been overestimating how long those took in some of these initial values, but when asked, people said it just didn't take very long. And all these things are relative, so you have to figure out, well, if this takes you 45 minutes and scoping a knee takes you 45 minutes, are those kind of similar? what's the intensity as they compare to each other, but it's a whole relative system. So positive news always is what I get to deliver. Now, what's coming beyond December 2022 and now into 2023? Well, we actually, there were codes recently created and valued for both cryoablation as well as radio frequency of the posterior nasal nerve. So those codes were created in the fall of 2022. They were valued in January 2023. They go through a process where that valuation is then looked at by CMS, by Medicare. Medicare then says, well, we agree with that valuation or we don't agree with that valuation. If they don't agree, then we get to argue with them and say, well, this is why we think you're wrong. But unfortunately, you're arguing with the people who made the decision in the first place, which never really gets you far. Oh, I think you were wrong. Well, no, we think we were right. Okay, argument over, I guess. And then these come into the fee schedule in January 2024. Those are new codes. Any questions on those? And I got otology and rhinology in there, which is always nice. I'm bridging the gaps. The remainder of the time I want to spend is on E&M coding, because I think that this is probably, let's face it, these are the codes we use the absolute most in our practices. And there were some big changes that happened in 2021 that we all had to adapt to in terms of how do we code E&Ms. And what I want to do is give at least what I think is a little bit just kind of simplified look at it to just give you a sense of how you can best document and code all of those office visits that you're doing. So when E&Ms were revalued, these were the 4 goals that CMS basically put forth. They said, we want to simplify this. And this is what we want to achieve. We want to decrease some administrative burden. We want to decrease the need for audits. We want to decrease unnecessary documentation. And we want to make sure that the payments are a little bit more even. So what were some of the major changes that happened? Well, 99201, this level 1 code that pretty much almost never, a physician never used, was deleted. Makes sense. No one was really using it. The most important thing is that codes are now based on medical decision-making or time. That's what determines which one you choose. It's not how many systems you reviewed. It's not how mmany components of the history that there were. It's based on one of these 2 factors, and this is what you bill based on. Codes were increased in work RVUs, but if you're doing 90-day global surgeries, you may not know, those codes have E&Ms built into them. So if I do let's say a thyroidectomy, there are post-operative visits built into those codes. You get paid at that time for something like a couple 99213s in the office. Those didn't increase. And why? Well, the answer to all of your questions is always money. There wasn't enough money to increase those, so they kept those at the same work RVU and reimbursement rates. So let's talk a little bit about time. If you're billing based on time, that is the total time on the day of the encounter, face-to-face or non-face-to-face. All of these things that are listed are things that you can document and use to justify the time that you're spending. Getting ready to see the patient, getting a history, doing a physical, counseling, ordering meds, talking with other healthcare professionals, documentation, doing your notes, any kind of care coordination, or independently interpreting results. Think about this. We do this a lot. Now, it is on the day of the procedure, the day of the visit. You want to keep that in mind. But who doesn't review the charts before going in to see a patient? Everyone does. Just about. And if the amount of time that you're taking allows you to then justify a certain level of billing, you can bill like this. Now, what you shouldn't say is, I spent 20 minutes with the patient. Because that's not detail-oriented. That's not going to be helpful. What'd you spend 20 minutes doing if you didn't do there's sometimes where I won't do a physical exam. I'm counseling somebody about surgery. They're coming in. So I want to document what I'm doing during that time. Or was I communicating with other physicians trying to coordinate care for a particularly complex patient? I want to document that time. So, well, what about a history and physical? Well, those aren't parts of the billing anymore. Now, you should do that if it's medically appropriate, because it probably is, and it's good practice. And by the way, none of this has anything to do with any kind of risk management, legal, potential things like that. This is all billing. So, but the extent of your history and physical, where you got to have 7 systems or 12 systems and things like that, that doesn't matter anymore. These are the new patient codes that exist currently, and these are the times that are associated with them. So level 2, 15 to 29 minutes of total time. Level 3, 30 to 44. Level 4, 45 to 59. And level 5, 60 to 74. These are the new patient codes. These are the follow-up codes. 99212, 10 to 19 minutes. A level 3, 20 to 29 minutes. 214, 30 to 39 minutes. And a 15, 40 to 54 minutes. The one thing I would say, if you are documenting by time, make sure it's accurate. Let's say you see 30 patients in a day, and you start documenting things like, well, I spent 60 minutes with each patient. That's going to be a weird look right there if somebody ever looks at your charts. And getting back to what Greg said about electronic medical records, people can see how long you're in an electronic medical record and what the time is that you start and what the time is that you close it. So you want to be appropriate, you want to be accurate, but all these things that we all did that we kind of never thought were billable, like prepping for clinic, like reviewing records, like going over scans, that's time. So don't discount that. The second part of this is medical decision making. This is complicated, but my hope is to make it a little bit simpler. This is one of the ways that you can bill. You can bill on time, but you can also bill on medical decision making. And there's 3 factors that go into medical decision making: number and complexity of problems addressed, amount and/or complexity of data reviewed and analyzed, and risk of complications and/or morbidity or mortality of the patient management. This is a slide that is from the AMA, and what it does, it's a nice chart which really allows you to accurately pick your code based on medical decision making. If we look at these 3 elements that I just laid out, you have to hit 2 of them in order to catch whatever code you're talking about. So what do I mean by that? Well, if you are, let's say you're picking a 99203 or a 99213, you have to hit 2 out of the 3, number and complexity of problems addressed, amount or complexity of data, or risk of complications. You don't have to hit all 3 of those, but if you can pick out 2 of those, then suddenly you've met that level. This is where I think it kind of gets interesting. If you look at this and you start thinking about the type of patients that you see, I'm going to bet that you are likely undercoding. Number of complexity of problems addressed for a 99203, low. So one of 3 things you got to hit: 2 or more self-limited or minor problems. We probably do that in most patients, new or follow-up. Or 1 stable chronic illness. Well, we almost definitely are hitting that. Or 1 acute uncomplicated illness or injury. Certainly, if someone's coming in, for a sick visit or something to that, you're catching that. Now, getting to the amount and complexity of data. Now, 2 separate categories in this, and you got to get the level for 1 of the 2. So first of all, tests and documents. Any combination of 2. Review of prior notes from each unique source. Again, we do that a lot. Reviewing the results of a unique test. Did you look at a CAT scan? Were you reviewing their ultrasound? Or ordering a unique test? I'm going to go do something else for this person. If you catch 2 of those, 2 of those 3, you've suddenly now met that criteria. Your other one is an assessment requiring an independent historian, which is so vague, and I've asked so many questions about that. I think that gets into the details of history and the amount or complexity of the data. And then lastly, risk of complications, a low risk of morbidity from additional diagnostic testing or treatment. Now, let's go to the next one, level 4. And this is where I think maybe you'll notice some maybe Maybe some of your level 3s actually are level 4s. So here, again, you're still hitting 2 of these 3. 1 or more chronic illness with exacerbation, progression, or side effects of treatment. Think about your patients, and when they're not doing well on a chronic disease, that suddenly hits that. 2 or more stable chronic illnesses, chronic sinusitis and asthma. Are you just helping to manage their asthma? Are you doing anything with that? Well, then suddenly you've hit that. 1 undiagnosed new problem, or an acute illness with systemic symptoms, or 1 acute complicated injury. And then getting into the complexity of data, tests, documents, or independent historian, any combination of the 3. Review of prior notes, because now you got to get 3, not 2 of them. Review of the results of each unique test, ordering of a unique test, assessment requiring an independent historian, or an independent interpretation of a test performed by another physician or other qualified health professional not separately reported, or discussion of management or test interpretation. Discussion of management or test interpretation, I bet we're doing that. I could almost guarantee that. And then getting into moderate risk of morbidity from additional diagnostic testing or treatment. Decision regarding minor surgery with identified patient or procedure risk factors. Decision regarding elective major surgery without identified patient or procedure risk factors. And I'm unclear what a elective major surgery without procedure risk factors would actually entail. Or diagnosis or treatment significantly limited by social determinants of health. And then lastly, getting into the level 5, and I'm going to focus more on the high risk of morbidity. I'm going to focus more on the morbidity from treatment. Drug therapy requiring intensive monitoring for toxicity. Decision regarding elective major surgery with identified patient or procedure risk factors. Decision regarding emergency surgery, hospitalization, or a decision not to DNR. Now, I don't have an answer for what's a minor surgery or a major surgery or things like that. You just heard some talks that would sure indicate that endoscopic sinus surgery is a pretty major surgery. It's got potential real problems. And as we get into the afternoon and you start talking about some of the otologic surgeries, these are serious things. My discussions for surgeries are almost always level 4s, whereas that was not the case before. That was not the case for me. Now, and it may be a level 4 based on this. It may also be a level 4 based on time. It really depends. But the medical decision-making justifies more than you think. Now, I'm not suggesting we're gaming the system or things like that. Honestly, we're just doing what we're told here, you know? And at this point, you're being appropriately reimbursed for the work that you are doing. These are the new values.
Hey Pete.
Yeah.
Before you jump on, how documented timestamping is easy. You know, I spent 30 minutes, 50% face-to-face discussing this, and this.
Yes.
How do you document this stuff? And do you have to, or can your note just speak for itself?
I think, especially as I think about it a lot with surgery. I start documenting risk factors with surgery. So we talk about consent and the conversation that happens around that. And so I document a lot of those risk factors that are associated with surgery, sort of heightening it. I gotta tell you, I also, and I did this before, I counsel people when I put them on steroids a lot about different things. And so I talk more now in my notes about the risks that are associated with that. So that's at least from that standpoint. The other stuff kind of comes from these are my diagnoses. I'm diagnosed number 1, chronic sinusitis. Number 2, asthma. Number 3, inhalant allergy. Whatever it is, but you're really kind of delineating that. Because if you're ever audited, you can go back to that and say, here's my 3. Here's my 3 conditions. Well, what was your risk of morbidity from testing? Here's the surgery that I'm performing. Here's my risks that are associated with it. They're all clearly spelled out in my note. I think it minimizes your opportunity to have problems.
So if I'm hearing you right, the note speaks for itself, or should. You don't have to go through and say this is a moderate risk or morbidity from this. This is a moderate because of these 3 categories.
Correct.
Awesome.
The note should speak for itself. Yes.
Do these same rules apply for coding for inpatient? Are you going to discuss inpatient consults?
Oh, I'm not going to discuss inpatient because they just changed. Darn you. They're actually very similar. Catch me in a year and I'll have it all set. But They actually did the outpatient E&M codes first, and then they have recently changed the inpatient E&M codes, and those are brand new. The other thing that you don't see here is you don't see consult codes. And the reason you don't see consult codes is because Medicare doesn't recognize consult codes. So they were like, well, we're not changing those because we don't believe in them. So I am standing between you and lunch, but there's two other things that I want to talk about. These are just the new values. And so you could see the difference of where things were and where they are now. So a 99213 in the past was 0.97 RVUs. It's now 1.3. A 99214, that was 1.5 RVUs. That's now 1.92. These are changes that are they're significant. When you're seeing a lot of patients, that's a lot. And again, you're likely doing this work anyway. You just need to document it in a slightly different way. Okay, shameless plug time. Because the other things that we do, this is all coding and all that kind of stuff. The other thing we do as an organization, as the American Academy of Otolaryngology and as the American Rhinologic Society, we try and advocate for members. It's one of the benefits of being a member. So when there's payer policies that are problematic, there's a lot of them. They're always problematic. It's like playing whack-a-mole a little bit. But we actually want to whack the mole because otherwise they're all going to come up at once, and then we're kind of overwhelmed. So here's my asks. Keep national organizations informed about problems that you're having. The ARS website actually has a form that you can just submit an issue, and you will get a response. Either from myself or some other folks that will tell you. Now, we don't do, and then this is actually an email for the advocacy staff at the Academy, and you will get a response. Now, we're not going to fix your billing problem, and I feel bad about that because I like helping people. But what do we use that for? Well, we use it to identify trends. If there is something particularly problematic, we will act on it. But also, if we start to see this thing in Washington and Virginia and Maine, hold on a second now. This has got a little bit more legs. We got to address this. So getting that information is very helpful. But then also remember that we have limited resources. Our Academy reimbursement staff was, until about a month ago, one person. Now it's 3, which is great. But it was one person doing all this legislative, private payer, everything. Engage, engage, engage. For those of you that are sticking around for the otologic section, Dr. Backus is very involved with some of Washington State's congressional delegation. You can be too. You would be shocked at what kind of response you would get if you actually call up your congressman and say, I would like to meet with you. I'd actually like you to come to my practice and see what's going on. You'd be stunned. Now, most people say, like, I hate politics, though. I don't want any part of this. Politics sucks. Politics does suck. I was going to do politics, and I don't because politics sucks. This is not politics. This is advocacy. You are standing up for yourself because nobody else will. And in keeping with that, standing up for yourself, you need to give money. So shameless plug. Our national organization has a PAC. That's a QR code that'll take you to the website. I couldn't remember the number. I knew that the orthopedic organization has 20% of their members that contribute to their PAC. Any guesses on what otolaryngology's number is for 2022? Oh, you guys are so optimistic. That's so sweet. I love it. 1%. 1%. Now, you might not like this, but it is what it is. Money buys access. And when you get the ear of those people, they actually listen to what you say. Not on everything, not always, but we have now been able to develop relationships with policymakers where they call us with questions about what we think about certain legislation. And that is going to be very important in the future in terms of scope of practice, all sorts of other legislative priorities. So that's my shameless plug. These are my conclusions. Thank you very much for your time, and thanks for sticking through.
Thanks, my friend. Great job.